I'm on the land. I'm on the lands of the Wurundjeri people of the Kulin Nation, and I would like to also acknowledge any elders who may be with us today and elders past, present and emerging. I am going to speak to you today about the ANMF 10-point plan to end occupational violence and aggression. I'm the OHS team manager at ANMF. I've been with the ANMF here in the Vic branch for just over 13 years now. When I started here all that time ago, I remember being particularly disturbed and distressed by how much OVA we saw, and I apologise for using OVA. It's just vernacular that we use all the time now. OVA meaning occupational violence and aggression. When I talk about violence and aggression, or OVA, I'm talking about the violence and aggression that's perpetrated by others, usually external to the organisation. They may be, for us in our circumstances, patients, visitors. They might be strangers to the organisation who just happen to have turned up. And so that's how we deal with the violence and aggression. We deal with the violence and aggression that is perpetrated internally in terms of bullying and harassment, or perhaps discrimination or sexual harassment or other forms of violence and aggression. We deal with that in a slightly different manner here. However, a lot of the principles in the 10-point plan equally apply. So as I said, I'm going to talk about the ANMF 10-point plan to end OVA. I'm going to start with what it is, where it's come from. Then I'm going to talk to you about how it came about and what we've done to get it enshrined in our enterprise agreement here in Victoria. And also I want to make sure that I cover how it can be used in non-health workplaces, because we have had feedback in the past, or we have feedback in health workplaces from some management that don't really understand what the 10-point plan is all about. So I want to make sure that it's really clear about how it can help other organisations and other industries as well. So as I said, we'll go through the 10-point plan, the requirements, and how it helps our members as well. There'll be plenty of time for questions at the end, so please feel free to either sit on them and ask them through the end. I hope some of them I'll answer throughout, but of course very willing to answer anything that I can through at the end as well. So to start with, I just will set the scene as to where we've come from in Victoria in particular. Now, I don't expect that you would understand, that you would be able to read or interpret all of the different parts of this particular slide, but what I'm trying to demonstrate here is that occupational violence and aggression is not a new issue. In 2001, the ANF, as we were at that point, had our first zero tolerance to violence policy. So that's over 20 years ago now. That's how long we've recognised it as an OHS issue for our members. Since then, there's been various iterations of activity, of inquiries, of parliamentary inquiries, ministerial task forces. We've had WorkSafe guidance, we've had Department of Health and Department of Health and Human Services as they've been along the way. We've had Victorian Auditor General reports into violence against healthcare workers. So there's been a lot of work that's happened in the past, but the reality is there weren't a lot of significant changes that had occurred. And even as recently as 2016, we had 2016, 2017, we had $40 million dedicated to addressing violence and aggression in healthcare. But it was the inclusion in the public sector EBAs where we started to really see a change in terms of getting violence really into the eyes and into the minds of the employers, as well as our regulator in WorkSafe Victoria. Over the years, There's been so many different tactics that we've had. I'll start again. We've had various posters along the way. We've had our lanyard cards, which are about saying no to violence, but also about reporting. And the thing that really changed the conversation was when we started collecting the data around the number of incidents. And this happened somewhat by design, somewhat by accident. Every year, every 6 months to 12 months or so, we'd get contact from a media organisation who had realised that there was violence and aggression against nurses, midwives in healthcare for one reason or another. It might be that there'd been a court case. It might be that some data had come out into the public domain. And so fairly regularly, we would get asked by the media to provide a nurse who'd been involved in an occupational violence and aggression incident to speak to the media. At the time, we didn't have a dossier of nurses who'd been involved in violent incidents who were willing to speak out to the public for a number of reasons. And I don't think that that's a good thing to have anyway, because the effect on our members who've been involved in this kind of incidents is significant. I don't think the media really appreciated the fact that asking people to come and just speak out about their experiences, but not actually offering any solutions and not actually offering a means of addressing the issue caused further harm. So what we tried to do, or what we did, was we developed an online reporting system. We developed a system whereby our members could contact us. They would go online and they would fill in an online form to tell us about when they'd been involved in a violent or aggressive incident in their workplace. We weren't doing this to get the names of people to give to the media. What we did this for was actually so that we could start using the information and we could start working with our members at those organisations to get change, substantive change around what had happened. Because what we'd recognised was that over the years prior, we'd been involved in many different incidents where we'd been speaking to our members. And we found that inevitably there were consistent factors that were present or absent, as the case may be, which were contributing factors to the incidents occurring. But they were rarely recognised by the health services that we were working with. So we put this form together to try to get our members to contact us, let us know what they'd been through, and also so that we could actually work with the members to get change in the organisation, to identify the contributing factors, the root causes, and to get change occurring. So far, since 2013, we've had over 1,000 incidents reported to us. I think we're up to about 1,200. We know that this is absolutely only the tip of the iceberg in terms of the incidents that do occur. But what we also know is that 1,200 incidents is a huge number, and it's given us a large amount of data and evidence around the aspects of the 10-point plan that we put forward. So what did we do? At that point, we decided that we could just keep on doing what we were doing and keep on dealing with each individual incident as it occurred, or we could change the discussion. As an OHS professional myself, I really looked at the incidents that were coming through and the consistent factors that just kept coming up for me really spoke to what was a systems approach to prevention. So it was about really just treating OVA just like any other occupational health and safety hazard. We regularly heard, oh no, OVA is different, OVA is difficult, OVA is hard to solve. But the reality is, when you've looked at so many incidents, you've seen what the factors are. OVA can be treated like any other OHS hazard and look at the root causes and the contributing factors. So using a systems approach to prevention of OVA basically integrates it into an OHS risk management system. But in the healthcare environment, OHS risk management can be somewhat distinct and disparate with the clinical management, and that's a problem. So with OVA, it needs to be incorporated and included within risk management, clinical assessments, and any other dealings with persons. And I think this is where the 10-point plan in itself really does lend itself to being applicable across industries. Because whilst when we talk about the 10-point plan, we talk about patients, or we talk about residents, or we talk about clients, depending on the setting, the reality is they could also be, you could talk about students in an education setting, you could talk about customers in a retail or hospitality setting, you could talk about prisoners in a custodial setting. And there's not many changes that need to occur for the same factors to be relevant. I think the difference between the systems approach was really in the basis of its prevention. Up until that point, there'd been a lot of work around how to deal with occ violence and aggression after the fact. How do you support staff who've been through an incident? But there'd been a real acceptance that it was difficult to prevent. So tackling it from a systems approach really lent itself to saying, okay, well, occ violence is something that we're going to prevent, and we're going to look at how we can stop it from happening rather than just mopping up afterwards. But the real thing about the systems approach that was significant was about learning from instances where the system failed. We knew about so many instances, we knew about so many different incidents that had occurred. And in those incidents, the system that was supposed to be protecting those members of ours had failed. And we weren't just going to accept that it's going to happen and that it's going to happen again. But we were asking about, well, what can we do to stop it happening again? And that was a change in the discussion. So I'm going to relatively quickly touch on the 10-point plan and what it incorporates. It's just an overview, and I will send through the link. I'll put the link in the chat later about where you can get the guide to the 10-point plan for more detail. But the 10-point plan is actually based upon two primary settings that must be in place before you could even possibly have any success with the 10-point plan. You have to have a workplace that has communication, consultation, and collaboration in place. And I'm not just talking about a workplace that has that pays lip service to consultation and collaboration. I'm talking about a workplace where HSRs and workers are involved in the workplace, are asked about what's going on, and are valued for what they can bring to that workplace. The other thing that was really critical for us in the health sector is to have a government and a health system who were committed to OVA prevention and who also believed that OVA could be prevented. And on top of that is a public who also understand that OVA is not acceptable in any form. Once we got those two in place, and once you have those two, then that's where the 10 points start to come into play. So the first point, and I'd like to make it clear that these points are in no particular order. They're not in order of importance. They're just a random order, because it's absolutely critical that all of the 10 points are in place, because without them, if something's missing, you still won't be able to have a full systems approach. So the first point is security. Now, when we talk about security in the health sector, we often have people talk about security guards in emergency departments, and the conversation comes up about whether they should be armed and what should they be doing. But security is much bigger than just having people. People is potentially a big part of it, but it's not just having people. You've got to have the right people. You've got to have people who are appropriately trained, who understand the system that they're working in. But you also need things like CCTV. Now, CCTV, again, on its own, not helpful. It's not helpful to have a CCTV system that records incidents of violence, but does nothing to prevent them, doesn't have anyone monitoring it who can assist in those circumstances. CCTV can be a small deterrent in some circumstances, but that is part of a broader security system. The same thing goes for duress alarms. Often we'll go into workplaces where there's duress alarms in place, but there's no one to respond to the duress alarms, or there's alarms that are attached to a wall, but you can't reach them if you're held up against another wall. So it's looking at all of the appropriate security aspects for that particular workplace. And that's where security audits and the like come into play. So the second point is about the identification of the risk to staff and others. Now, this is where the real OHS aspect comes into play. This is just about hazard identification and risk assessment. So there's no difference between this aspect when you're looking at OVA and looking at bringing in a new machine into a workplace and doing a risk assessment to find out how it works, what happens, how it should be used. This is exactly what we're talking about when we're talking about identifying risk to staff and others. When a patient comes into a hospital setting, there should be a risk assessment. That risk assessment should include many factors: clinical aspects, falls aspects, manual handling needs, but it should also identify whether there's any occupational violence risk presented by this particular patient. This can be done by looking at their history, looking at whether there's alerts when they've been in the workplace previously. It can be done by assessing them at the time as well. So it needs to take into account a whole lot of different aspects, but it needs to occur preferably before someone comes into the setting. So that can be where you have planned admissions, or you have someone transferring to another facility, but otherwise as soon as they get there, just like any other OHS change that happens in a workplace. It's critical that clinical staff and those looking after the patient are involved in that risk identification process. It's not enough to have perhaps one doctor or who rarely sees the patient make that assessment. It's got to be a multidisciplinary assessment. And it needs to continue throughout the patient's stay as their condition changes. While we're doing risk assessments, it's important to look at the family, the visitors, and other people who might come in to visit a patient or a resident. So often it's not the resident or the patient themselves who's violent. It might well be the family or the visitors who come in to visit them. And so once that risk assessment's been done around them, then it's critical that those assessments are all included in the patient care plan. So where you have a patient and you have their information, the patient care plan is what our members use to provide the care and to understand what the risks are with each individual patient. So we want those risks identified, and we want the strategies that have been put in place to reduce the risks. We want that included in the care plan. So one thing that we find is done particularly poorly is around the investigation of incidents. We know that our members have difficulty reporting in certain circumstances. It may be because of the incident that's occurred, but it might also be because they've been reporting for 5, 10 years and nothing's changed. But that reporting is absolutely critical, because without that data, then it's really difficult to instigate change. But once those incident reports are done, then it's incumbent upon the facility to actually investigate the incident report and look deeper than just Mrs. Jones wasn't feeling well, or you shouldn't have approached them at that time in that manner. That's not an incident investigation. An incident investigation really gets to the root cause of what were the contributing factors to this particular incident of OVA. And once those factors have been identified, then action needs to be taken to make sure that these don't recur. Workplace design is just as critical with prevention of violence as it is for many other OHS issues. There are CPTED principles, crime prevention through environmental design, that can reduce the risk of violence occurring. It might be that you're improving the lighting in the car park. It might be that you're increasing the height of your benches. It might be one that came up particularly for us throughout the process was, as many of you I'm sure are familiar, but in emergency departments, there's often screens between the patient and the triage nurses. Those screens in themselves can sometimes cause frustration and difficulty, because some of those screens are such that patients have to yell from the other side, from the waiting room side, to get their information through, because they can't be heard through the screen. So you want to be careful that what the design features that you're implementing aren't going to increase frustration or potentially increase violence in themselves. So we looked at a number of those, for example, and came across different ways that those screens could be implemented where they were better and less likely to cause the issues. But there's many different violence design principles that need to be considered. It might be the blind corners in a mental health unit where clients might be able to hide without being seen. It might be aspects of wards where you have rooms that are far away and isolated from other staff members, and therefore it increases the risks associated with people going to them. So as I say, there's many different aspects of the workplace design that need to be considered. Of course, critical in all of this is education and training for healthcare staff. This seems to have been the primary control of choice in the past, because it's been thought to be relatively simple, but in and of itself, it's not enough. There's no point training and educating healthcare staff around de-escalation techniques if they're not going to be able to access backup when they call for it. And I think the education and training that has been provided in the past has also been relatively limited, because it's been only talking about, for example, de-escalation techniques, but doesn't talk about how do you undertake an incident report? How do you undertake an incident investigation? How do you do a clinical pre-admission risk assessment to try to identify which patients might be higher risk of OVA in the future? So the education and training has to be broad and it has to be consistent. Integration of legislation and policies and procedures might sound complex and is quite far-reaching, but the reality was, the further we dug in when we were looking at incidents, the further we found that even within each individual organisation, often their own policies and procedures would be contradictory. So, for example, in one policy, it might say that when you call a code grey, which is where you have a patient who is, you have a situation where the patient is threatening with a weapon or there's actual violence occurring at the time. When you call that code grey, In one policy, it might say that you have a particular response which involves 3 people, but then in another policy, it says when you call a code grey, someone automatically calls the police. So this lack of integration and consistency between policies, procedures, and the legislation causes confusion, because people in the moment, people don't know where to go. People don't know where to look. And if they look at one policy and it gives them one lot of information, they're not going to go and look for another one. So it's a critical piece of the puzzle to have a look at the system from a high level rather than just each individual policy. Post-incident support is something that we were aware was occurring, and we would have anticipated was actually being done quite well, but the reality was even that was still being done really poorly. Members, after they'd been through a violence incident, were often sent home. They might have been sent to the ED if they needed to be seen there, but were often sent home and not followed up for days, weeks following the incident. And that leaves them feeling isolated, alone, and despondent. They feel like they've been completely tossed aside by the organisation. Post-incident support can't be a one-size-fits-all approach. Support is what that person needs at the time. But asking the question is an important part of that. Managers contacting people after they've been through an incident and saying, is there anything I can do? What would you like from us? What can we do? Here's some options. And providing that information is actually really critical. Because sometimes we found, or often we found, that it wasn't the incident of violence itself that caused the long-term injuries, but it was the lack of follow-up and the lack of support following the incident that really consolidated the distress and the ongoing psychological injury following a violence incident. Applying an anti-violence approach across all health disciplines is significant to make sure that you don't have healthcare staff basically being pitted against each other. So you don't want to have, for example, the doctors with one set of expectations around what violence is, what should be reported, and what the follow-up should be, and then having a separate set of expectations with the nurses, separate set with the midwives, separate set with the security guards. So it was really important for us to actually bring everyone together who's affected by this and have them share the same vision, share the same expectations, and be involved in the process together, all take responsibility for their own part of the process. The reality is we found one of the best ways of achieving this was to have the education provided consistently. So having all the people in the room together to get the training at the same time, because then they could share their expectations and share their experiences. And finally, it's about empowering staff to expect a safe workplace, because if you have staff who believe that violence is part of the job, then the rest is not going to work. It's really about providing that support, showing that there is a real determination to change, showing that staff shouldn't have to expect that violence is going to occur, and therefore then being able to report. So if staff expect that they are going to have a safe workplace, they'll report their incidents. They'll give the evidence. But if they don't, that's not going to happen. And if you don't have reporting, you don't have opportunities for improvement. So as I said, that's a very brief overview of the 10-point plan. There's a lot more detail that goes into it. But what we did was we put this into a plan, and we ended up managing to get the leader of the opposition, as he was at the time, Daniel Andrews, to sign up to committing to implement the 10-point plan as an election commitment. At that time, that was, of course, a lovely a lovely sentiment, and that was great, but it's really about what did we do from there and how did we actually get that practically moving. So at that point, we negotiated into our public sector enterprise agreements to include an occupational violence and aggression clause. The reason we did this was because in the past, without that, we weren't getting any traction. We weren't getting recognition from the health services that things needed to change, nor commitment to actually doing it. We were getting lots of, it's difficult, it's hard, there's no answers, how do we do it? And so we thought, well, the only way we can do this is to actually provide the answers. So there's lots of questions, so let's provide the answers. So we developed the 10-point plan as an overview. We've got an overview guide, but we've also developed a guide for health services, which is a much more detailed approach. And it gives, under each of those 10 points that we went through, it gives criteria that we want the health services to implement. So for example, and this is very difficult to read, I understand that, but as I say, I'll give you the link to the actual guide. This is a sample of what some of the criteria around security look like. So we have a number of criteria for security, as you can see, 1.1 to 1.4. But then what we've done is we've provided a traffic light approach. We've provided what the high risk solutions, or the lack of solutions as it is, look like. We've also provided a bit of a roadmap to how to get to what looks like a low risk solution. So the reduced risk is on the way from high risk to low risk. This is where the health services might end up, but then low risk is where we actually want them to be. So you might be able to see there, but for example, we talk about security audits of all established staff areas, safe zones, lockdown areas, and procedures having been conducted and recommendations having been implemented. So that's what it looks like when you've actually got a low risk solution. So there's lots of those criteria within the guide. So what we did was we provided the answers so that we provided the state of knowledge around what it looks like into the future. So what do the EEBA requirements actually look like? So all employers under our Nurses and Midwives Public Sector Agreement in Victoria have to have an OVA action plan, which is consistent with the 10-point plan and WorkSafe Victoria guidance. And the action plan has to outline the actions necessary to improve security. It has to implement proactive measures. It has to ensure a reporting culture and provide appropriate support following workplace incidents. So these action plans, so as I say, every employer under the Public Sector Enterprise Agreement in Victoria is required to have one. So we're talking about just over 100 of our public sector hospitals and health services. They have to have this action plan, and we found that that's been a really positive and proactive approach to making change. We're very aware that it was going to be impossible for employers to implement all of the aspects of the 10-point plan immediately, and so it was about building a plan to get better. Additionally, under the EEBA, they have to have a committee that's responsible for overseeing the actions required to address OVA. And importantly, that committee has to report to an OHS committee. So that brings OVA into the OHS sphere. It's not about it being a clinical risk, which is where it's been seen in the past. It's making it an OHS risk and keeping it within the OHS risk management framework. And they have to have an OVA policy which is consistent with the 10-point plan. So in order to ensure that those requirements are involved, we actually sit on many of the OVA committees across the health services to check that those OVA action plans are progressing. But I think it's important to also talk about what else we do for members when they call us with an incident. So as an individual, if you call the ANMF and tell us that you've had an incident of OVA or fill in our form, We provide individual support for any members who tell us about that. We address the issue with their employer if that's what that individual would like, but we also provide them with work cover support and representation. We support them through the process of raising the incident with police, and depending on what they need, we provide that case-by-case support. But more broadly, we also deal with the incidents on that systemic level. We raise the issues with the employer when incidents occur to make sure that we address the identified concerns. We make sure that we look a little bit deeper and find out what's been going on, what's failing, what's working, and try to get those changes happening. And we also, where we have employers who are not covered by the public sector and might not have that mandate to have an OVA working group, we will often suggest the development of an OVA working group where there's OVA issues to help them work out an action plan. And we'll be involved with that with our members and our HSRs. I think it's, at this point, I would highlight that it is absolutely critical that at all times throughout this process that it's about the members and the HSRs who are involved and who are giving us the information back. We can't do it without them. The members and the HSRs are the critical, that critical conduit of the information that we need. We can only do so much without feedback. The employers will often tell us that they're doing things, but it's the members and the HSRs who are the ones who say, well, that's actually not quite right. Or if there was training that happened, I didn't know about it. Or it might also be that, the training that happened really didn't address the issue, and so we need more training. So I'm going to stop sharing my screen at that point, and I want to just talk about briefly what this looks like and how this can be implemented across non-health workplaces. And the reality is, as I said earlier, the 10-point plan, whilst it uses patients, it uses health services, it uses aged care facilities in it, those words are basically interchangeable with student and school, or retail worker and workplace there, whatever it might be, because not much of what's occurring in our workplaces is extraordinarily different to what's occurring in other workplaces that are experiencing OVA. The difference perhaps is that we have patients and residents who we can't always remove from the workplaces. They might be too ill, they might have a need to be there, whereas other workplaces that might not be the same. But other than that, the prospects, the principles are consistent. It's about taking an OHS approach, identifying the issues, identifying the hazards, assessing the risks, and implementing controls for those risks. It's really about taking it back to basics rather than letting people tell you that OVA is so difficult. I'm not going to say it's easy. It's a complex hazard and there's a lot of actions that need to be taken to address it. But identifying those actions isn't of itself a complex matter. There has to be the will, there has to be the driving force to try to get the change. But once you've got that, it can be addressed. As I said, we developed the 10-point plan as a roadmap. When we developed it, we had in mind, could this be used in other workplaces? Can this be used elsewhere? And certainly we're aware of other areas that have been adapting it and making it work for them. So I think that's probably where I will leave it from my presentation side of things, but I'm very happy to take any questions that anyone might have.
Kathy, I've got a question if you don't mind.
Sure.
So I guess I've been working I've been a nurse for the last 30 plus years. 27 of those years have been in the public sector in Australia and the UK. In the last 4 years, I've actually worked in the private sector, and you touched on briefly there around, what the private sector's responsibilities and whatnot are. And one of the concerns that I have, and you mentioned it as part of your 10-point plan, your EEBA agreements and requirements, is that they just apply to the public sector nurses. We also had, I think it was back in 2016-17, where the Victorian government said that it was mandatory for every public healthcare facility to have a code grey response. Now, at that point there, I was working in the private sector, and basically what we were told, well, it doesn't apply to us, we don't need to do it. So what are the ANMF, and I'm a member of the ANMF, what are they and the government doing to actually improve the safety of members within the private healthcare?
Yeah, look, John, that's a great question. I think it's really important, and you've picked up on a couple of points there. So certainly for all of our private sector agreements, as we're trying to negotiate those, one of our claims that we are pushing is to get a similar OVA clause into our private sector agreements. It hasn't been particularly easy for those. But having said that, we're still pushing it. But irrespective of the clause in the agreement, one thing that having the 10-point plan and having it in our public sector agreement has done is that it's changed the state of knowledge around what acceptable controls and what known controls are available for OVA. And the same with the code grey standards for public hospitals. Whilst it might not be directly mandated by the government, what is reasonably practicable under the OHS Act incorporates an element of the state of knowledge. And so that was one of our big motivators. We knew that by developing the 10-point plan and the guide, we would be able to change that state of knowledge. And what we did was we've provided very clear guidance around how it can be addressed. It's reasonably practicable. There's nothing in there that costs significant amounts of money. There's a lot in there that requires will and requires determination to make the change, but it doesn't cost a lot of money. So we're continuing to progress that. We are often dealing with WorkSafe as our regulator around incidents that occur in the private, public, residential aged care and everywhere in between. And we do refer back to the 10-point plan as a state of knowledge. We've actually presented to WorkSafe around the 10-point plan ourselves so that the inspectors there also understand that, you know what, this is what can be done around OVA. It's, yes, whilst it's a tricky, complex hazard, it's also, there are also very well-known controls that can be implemented. So we're continuing to pursue it in the agreements, but just because it's not in the agreement doesn't mean that it's not applicable.
Thanks, Kathy.
You're welcome.
Amazing. Thank you, Kathy. And does anybody else have any other questions? You can just speak up or send a question in the chat. Cool. All right. Well, I'll take it then that you have done an amazing job, Kathy, presenting all of the information. And because of that, nobody has any questions. So yeah, we'll leave the webinar at that.